Dr. Yagnesh, Dr. Kashi, then other speakers, immunization and the antibiotic and everything is covered. And now today we have lucky to have a eminent speaker. So I invited Dr. Edith Shantakumar to welcome the audience.
So good evening to each and everyone assembled for the meeting. A warm welcome to all of you on behalf of Thrissur IAP. The topic today is indeed a very important one: the judicious use of lab investigations in pediatric infectious diseases. In our day-to-day practice, it is so easy to just write a whole array of investigations after examining our patients. But let us take a pledge today to remember to go slow, take a deep breath, consider our patient in full perspective, and then write our tests carefully and cautiously. Today, our speaker on this topic is Dr. S. Balasubramaniam, Head of Department of Pediatrics at Kanchi Kamuti Hospital, Chennai. Hearty welcome to you, sir, and awaiting eagerly to hear your valuable talk. I welcome and thank our moderator for the session, Dr. Ananda Keshwan. He is the past National President, Vice President of IAP's National Vice President, and he has taken a lot of pain in arranging the speaker for the meeting. Thank you and welcome. Dr. Anju, our dynamic chairperson of the infectious chapter, will be delivering the presidential address. Warm welcome, madam. Inauguration of the session will be by Dr. Jairam, our IAP state president. He is really very busy, and I thank him for consenting him to be here amidst us for the inauguration. And I welcome you, sir, on behalf of Thrissur IAP. Felicitation today will be made by Dr. Johnny, State Secretary, Kerala IAP, Dr. Mukesh, Vice President, Kerala State, and Secretary of the Infectious Disease Chapter, Dr. Nihas Naha. Hearty welcome to each one of you. Welcoming Dr. Srijit, our branch secretary, who is a silent and strong member of the branch. I can see that there are many senior members assembled here: Dr. Yogesh Parikh, Dr. Abraham Paul, Dr. Sarojam, and all those who are here. Welcome and welcome to each and every one of you. And I invite now Dr. Anju for the presidential address.
Thank you, ma'am. Good evening, Jayaraman sir, Johnny sir, Anandakeshavan sir, Rati madam, Dr. Srijit, Balasubramaniam sir. I'm extremely happy on behalf of ID Chapter Kerala to welcome Thrissur IAP for their fourth series of I-Square. Thrissur kickstarted the program very well, and they have brought expert speakers from all over India and they are continuing the program well. And other districts have also roped in for the programs. We had a very good program by Kollam IAP, a half-day program last month, and next month IAP Alappuzha is conducting a ID chapter program. I wish all the success for this program. And for today's talk, we have an exemplary speaker, Balasubramanian sir. I welcome you, sir, on behalf of ID chapter. Over to you, ma'am. Debbie, ma'am. Thank you.
Unmute, unmute. I invited Dr. Jairam sir, the state president, to give an inaugural address.
Good evening, everybody. Respected President of Thrissur IAP, Dr. Rati Shantakumar, Dr. Anju Deepak, Chairman of the Infectious Disease Chapter of Indian Academy of Pediatrics, Kerala State, Dr. Mukesh, Vice President of IAP Kerala, Dr. Ananda Keshavan, former National Vice President, Professor Balasubramanian, the Speaker of the Day and Doyen of Infectious Diseases in Children, and national faculties, Dr. Subramania is there, Dr. Yogesh Parikh is there, and Srinivasan sir is there, and Dr. Abraham Bol, all the other dignitaries on the platform. I'm so happy to be associated with this a very important session on infectious diseases by none other than Dr. Balasubramanian. And I congratulate IAP Thrissur and Dr. Ananda Keshavan especially for arranging this very important CME program. As you all know, with the advent of so many laboratory investigations, I think we have slightly departed in usual practice from the order of history taking, physical examination, and coming to a probable diagnosis and then ordering investigations. Instead, very often people are approaching to diagnosis from the investigations part, and it is very worthwhile to have a relook into our practice on diagnosis of infectious diseases and using the medical laboratory in a judicious way. I wish the very best for this program, and I wish the very best for Thrissur IAP and Dr. Ananda Kesavan. Thank you.
Thank you, Dr. Jayaraman sir. Now I invite Dr. Johnny Sebastian, Secretary of IAP Kerala, to offer felicitation. Over to Johnny sir.
Good evening. Thank you, sir. Respected Chair, Dr. Reti Madam, President IAP Thrissur, IAP Kerala President and my leader Jayaraman sir, past National Vice President and Chairman, MBFHI, Ananda Keshavan sir, Yogesh Parekh sir, Chairperson ID Chapter IAP Kerala, Dr. Anju Deepak Madam, esteemed Speaker of the Day, Dr. S. Balasubramanian sir, Dr. Mukesh sir, Vice President IAP Kerala, my friend Dr. Neha, Secretary ID Chapter, the vibrant Secretary of IAP Thrissur, Dr. Srijit, seniors and dear friends in IAP. Let me congratulate IAP Thrissur office bearers in rolling out this series of talks, infections and immunization series, with the able guidance of a very energetic and dedicated leader like Dr. Ananda Keshavan sir. As we all know, pediatric infectious diseases accounts to the bulk of the cases we see in our day-to-day practice. To enlighten us more on the judicious use of lab investigations in pediatric infectious diseases, we have none other than a very popular speaker, Dr. Balasubramanian sir. I wish this CME all success. Jai Hind, Jai IAP. Thank you.
Thank you, Dr. Johnny. Over to Dr. Mukesh, State Vice President.
Dignitaries on end of the dais. First, let me congratulate the Thrissur team for conducting such an informative and very important topic for the discussion. And I wish all success for this program. Thank you, sir.
Thank you, Dr. Mukesh. Dr. Naha is there. Dr. Naha, State Secretary, ID Chapter. Now I invite Dr. Yogesh Parekh, our friend from far away from Gujarat, the main person behind the Gurukul program of IAP Gujarat. Over to Dr. Yogesh Parekh. Now he's working, I studied in Gujarat Government Medical Surat. Now he's working in the same institute. Over to Dr. Yogesh Parekh. Unmute, sir, unmute. Unmute, sir, unmute.
Yes. Thank you, dear Dr. Anand Keshavan. We remember you every day as our alumni of the GMC Surat. Thank you very much for inviting me for the very informative session and very expert faculty, Dr. Balasubramanian sir. It is what we can say. To hear the Dr. Balasubramanian sir, it is an opportunity. It's like heaven. We can hear Dr. Balasubramanian sir and we can learn from the sir's expertise knowledge. So thank you very much, all the office bearers, Dr. Jayaraman sir, Dr. Mukesh, Dr. Rati Madam, Dr. Nihas, and my friend Dr. Johnny, Dr. Simi there. So let us start the program. Thank you very much for inviting me, Dr. Anand.
Without wasting much time, we'll directly go to scientific program. Respected President Dr. Reddy Shantakumar, Secretary Dr. Srijit, Senior State President Dr. Jayaraman, Secretary Dr. Johnny, Vice President Dr. Mukesh, and the senior colleagues, Dr. K.K. Purushottam, Head of the Department of Pediatrics, Professor V.K. Parvati, Dr. T.D. Mudidharan, and the teachers of teacher Dr. Srinivasan sir, Dr. Yogesh, and my dear friends. It is fourth talk in our series, Infection and Immunization series. We had 3 wonderful sessions. Today we got an excellent topic and also a wonderful speaker. Today in Kerala we got 4 concurrent meetings are going on in the Zoom platform. Still we exceeded our audience, 100 plus audience there before beginning the program. That shows the interest in infectious disease in the topic. Of course, our great speaker, Dr. Balasubramanian. Balasubramanian was, I can say he's my teacher. I don't know whether he taught me some basics of the respiratory system as a dependent student. I went to Chennai to learn about OSCE when I was doing my, I was here assistant professor, but to see what is happening in the OSCE, I went to Chennai, Kanjigori, and I attended his class also. That is why I call him my teacher. And he's director and superintendent of the Kanjigori hospital. He's a very excellent teacher, interested in infectious disease and pulmonology. He is the immunization committee chairman. We know the IAP immunization committee guidelines, and the book also we are all received a wonderful book on immunization, IAP guidelines, and also Sir has written more than 100 papers in index journal, and he is examiner of MRCPH, and we are together in the National Executive Board member around 2005 at that period. There are so many things in history. I am not going in detail. He's a wonderful clinician, teacher, practitioner, and overall a very good human being also. Over to Dr. Balasubramanian sir. Thank you for accepting our invitation, and we are waiting for your talk.
Thank you very much. Please allow me to share the screen, Dr. Anandakis.
Okay, sir.
Thank you very much, the entire Kerala IAP. Thank you, my dear friend, Dr. Anandakis, and all my good friends in the IAP, and Dr. Anju in the infectious disease chapter, and several other senior members, including Dr. Yogesh from Gujarat. Thank you very much for inviting me today to discuss a very important topic. Because when Dr. Anju was speaking, she said judicious use of lab tests. For want of time, I thought I will deal only with microbiological tests. I hope it's okay with you, Dr. Anju. I thought I will restrict only to judicious use of microbiological tests in pediatric infectious diseases. The focus in my session would be, I always believe that we learn from cases. I'm going to pick up some common case scenarios and discuss and review use of microbiological tests and its judicious interpretation. And for every case, I thought I should put a bottom line as learning points, which I thought I have learned from such situations. And in the end, I will take up some questions from the audience. This is going to be the flow for my session. I straight away start with a very common scenario today amidst COVID pandemic. A 6-month-old infant, male, has fever for a day. Temperature is 103. The mother has noticed. There is no focus, and the baby is active when the fever comes down. And of course, the primary pediatrician has asked rightly a urine test, and it shows 20 pulses per high power field. And then the mother seeks your advice. And at this point of time, I said I will restrict myself to microbiological tests. If I might ask, what are the microbiological tests which are appropriate for this child? Then the answer would straight away come from all of you. Urine culture. Urine culture. Of course, we will do a urine culture for this child who has got fever without focus and who's got pyuria. Then the question might come up to the audience, what if the urine routine is normal? Okay, can this still be UTI? There is always a dilemma. Normal urine analysis routine Would it still be UTI? Because everywhere we read that the commonest cause of fever without focus in a young infant less than 3 years is UTI and UTI. Studies have shown 17% of all fever without focus is due to UTI. The points that you must remember is that even in the absence of significant pyuria, it can still be UTI, but it's not majority. Studies have shown 3% of urinary tract infections, the urinalysis might not show significant pyuria. So if there is no focus, if you still think it is UTI, a past history of UTI is there, you must do a culture. And all of us know the definition of significant pyuria, which is defined as more than 10 leukocytes per cubic millimeter in an uncentrifuged sample, and then more than 5 leukocytes if it is a centrifuge sample. Significant pyuria may be absent in about 3% to 10% of UTI. So always better to do a urine culture when there is fever without focus. This infant, the doctor, the pediatrician asked for a urine culture and started on cefixime. He started with a loading dose of 15 milligram per kg and then gave a 8 to 10 or 15 milligram per kg. The infant is better after 48 hours. The mother comes back after 48 hours with a report from a good lab. Urine culture is growing E. coli and it is ESBL. And the colony count is only 10 to the power of 4. And the lab reports it is resistant to cephalosporin, sensitive only to meropenem, amikacin, etc. Again, a dilemma. You are given cefixime, the child is better. The lab report frightens you. Child is better. Question is, what do you do? The next question is, somebody would say, the gold standard for diagnosis in a clean gas specimen is 10 to the power of 5. This is not satisfied in this case. What do you do? Do you repeat culture? And how do you interpret the colony count? These are the uppermost questions for us. If you find that the child had improved initially with cefixime, you can actually continue the treatment. There is always a discrepancy between in vitro and in vivo. So if the patient responds, there is no need. If the patient is stable, even studies have shown that 2/3 of patients who show resistance in the lab respond clinically in vivo. Again, interpretation of colony count, you must know how the urine is collected. There's no point in reading the urine culture report, or for that matter, a microbiologist giving a report of the urine culture without knowing how the sample is collected. So if it is suprapubic aspiration, even one bacteria is significant. If it is catheterized sample, it is 10 to the power of 4. If it is midstream, it is 10 to the power of 5. All of us know. A repeat urine culture in this child who was improved is not necessary if there is improvement in the clinical symptoms. There are some difficult decisions with regard to UTI which we have to make in practice. We find in practice mothers coming with multiple E. coli reports, child is well. What do you do? Mind you, this is asymptomatic bacteriuria. The ultrasound is normal. Child has not had pyelonephritis. Please ignore it. Counsel them. Look for voiding dysfunction. The next question is, there is so much ESBL. And everybody talks about ESBL only in India. It doesn't occur in US or UK. In India, majority of the strains are now becoming ESBL, particularly in the UTI. The next question is, how do you collect the urine for culture? In fact, whenever I see a child with suspect UTI and ask them to do a urine routine and culture, the entire family will be around the child, running around, not wearing gloves like Dhoni, but trying to catch a sample of urine. It's a horrible exercise for the family. And mind you, back collection should never be used for urine culture. The best in practice is catheterized sample. In fact, if you want to establish diagnosis, and if the child is febrile and is probably having acute pyelonephritis, to establish diagnosis, the best method is to simply catheterize, because clean catch specimen in an uncircumcised male and in a young infant is always very difficult, whereas catheterization, which is once thought to be serious and one thought to be injurious, now is considered the gold standard. Suprapubic aspiration, we have not done in our institution for the last 20 years. And clean catch is possible in older children. circumcised infants, and very patient parents and good wicket keeper family. Coming to the ESBL UTI, in India, 30 to 40, 50% of Enterobacteriaceae are ESBL resistant. In fact, we have our own data in our hospital. 40 to 60% of the last 3 years are all ESBL. But we have changed our policy. Now, in my own unit, we don't prescribe cefixime. We prescribe amoxiclav for UTI based on ESBL resistance. And we use amikacin in sick patients. The studies have shown you can use aminoglycoside. You must know the local epidemiology. So the bottom line in this case one is the most missed serious bacterial infection. I'm repeating, most misdiagnosed, underdiagnosed, inappropriately treated serious bacterial infection in pediatric practices, UTI. Collection is crucial. Colony counts, you must know there are a lot of caveats. In fact, if you go through the history of colony counts in UTI, the colony count of 10 to the power of 5 is based on adult women with UTI. It has not been validated in pediatrics. Just because it is 10 to the power of 4, the child is symptomatic. If you diagnose UTI, don't say 10 to the power of 5 is not there and don't say UTI is not there. There is always a discordance between in vitro and in vivo. You must understand that any drug, when you give, for example, cotrimoxazole, cefixime, which get excreted through the kidneys, very high concentrations are achieved in the kidneys and in the urinary tract. So, in vitro, in the lab, it may be resistant, but inside the patient, because of the high concentrations, the bacteria might be killed by the antibiotic. And always interpret the culture reports in correlation with all the clinical data, including collection of urine. Let us move on to the case 2. This is a child who has had fever for 5 days, 4-year-old child. Mother says the child is not very active, intake is poor, liver is about 2 centimeters, spleen is stripped. You have done a blood count, smear for MP, everything is normal, urine routine is normal, no urinary symptoms. One might ask, what are the appropriate microbiological tests that you will ask for? In practice, the only test in such cases will be blood culture, and blood culture. The questions that will crop up in your mind: how do you collect the specimen? How do you interpret the blood culture? And you must all be wondering, in urine we do blood colony count, in blood we don't do colony counts. The microbiologists don't do. How do you determine the significance if crons, coagulase negative staphylococcus, or some unusual organism like diphtheroids are grown? And the last question is, are pediatricians doing blood cultures? Let me try to answer one by one. Blood culture, the microbiologists always want you to give a lot of blood. We have BACTEC system, you get 2 bottles, and depending on the weight and age of the child, you must collect anywhere between 2 ml to 20 ml in an older child. Adolescent, you have to collect 20 ml if you want good results. Whereas in a newborn, even 1 ml has been proven to be sufficient, 2 ml will be ideal, and in between 3, 5, 10, depending on the age. This should be kept on your table. And you should give specific instructions to your nurse about the volume of blood. And she must send, nowadays automated blood cultures only are encouraged, not anymore sheep blood, agar, etc. And the interpretation, the earlier the organism grows, the more likely its significance. For example, contaminants from the skin take a longer time because they multiply from the skin, then go into the thing, and it takes a longer time for you to get culture. So delayed flagging could be a contaminant. Early flagging could be a true growth. In fact, we have seen many times in BACTEC, we'll send the culture in the evening, morning itself, the microbiologist will call us and tell us, sir, some gram-negative signals are there. That means it is typhoid. So early signaling is very, very significant. Late signaling may mean contaminant. And of course, you must know how to identify whether it's a contaminant or not. In fact, in our PICU and in very critically ill patients, in our hospital, we have a policy. We take 2 simultaneous blood culture, one from right and one from left, or one from the leg and one from the arm. This has increased the yield by at least by around 20%. That's our practice, though it may look costly, but it may be very, very crucial. I've always heard microbiologists telling me pediatricians, probably we are better than adult physicians. We don't do enough cultures. Is that true? And I have known many pediatricians raising in forum, Bala, you're talking about blood culture. You are working in Kanchi Kamakodi, you will get blood culture. I'm working in periphery and my lab does not grow typhoid. I go by only typhidot and vidal. Is that right? The answer to such gentlemen is, if your lab does not grow typhoid, ladies and gentlemen, please change the lab. The easiest bug to grow in blood culture is salmonella. And the lab is not growing salmonella. That lab, even if it is computerized lab, should be closed. If you can't grow salmonella, it's not a good lab. It's very easy to grow. And in India, it's quite common. And serology, mind you, typhidot, vidal, they are all moving out. In another 10 years' time, like Manto, typhoid and typhidot will undergo natural death and they'll be replaced by molecular tests. PCR is emerging even in typhoid. I'm sure in future, we'll be doing PCR on cultures, not vidal or typhidot. The most underutilized microbiological test in fever is blood culture. The culture of culturing needs to be propagated. And it's a very, very crucial test. If you miss the bus, for example, you have a child who has got fever for 5 days, you don't do blood culture, you start antibiotic, day 10 fever is not coming down, you'll be breaking your head. You'll end up doing bone marrow and whole body CT scan. Infective endocarditis, sepsis, PUO, blood culture is crucial. And nowadays, with the automated systems, the yield is so good, the results come so fast. Please make use of blood cultures effectively. Case number 3, 6-year-old child has been brought to you with 2-day history of high spiking fever and dysphagia, acute onset, nothing else, cough is absent, and you see vesicles like this, small vesicles in the soft palate and in the throat. No similar cases. I'm sure all of you would diagnose a Coxsackie virus infection, herpangina in this child. But mind you, then somebody might diagnose acute tonsilopharyngitis and ask for a culture. Is that the way out? In fact, if there is a clinical diagnosis like this, you don't have to do any tests. But if you have a doubt like this, you have a child who has got a red beefy tonsils and a red uvula and a little bit of exfoliation of the skin around and cheilitis, you know it is scarlet fever. You have something like this with a membrane like this in the middle, occluding the entire pharynx, you know it is diphtheria. You see a grayish white membrane with relatively healthy looking tonsils, splenomegaly, epitrochlear lymphadenopathy, you know it is EBV infection. So ultimately it is clinical diagnosis. But there may be some situations where you may have a doubt whether this is viral or bacterial. Is there a role for rapid antigen tests? And when do you do throat swab culture? What about ASO? Very many pediatricians are fond of doing it. And how do you diagnose EBV pharyngitis? Very simple. RATT is a very, very useful test. It is very cost effective. It costs only 100 rupees. You can use it with your experience. You can do it. The kits are available. You get a report within 5 minutes. In fact, we have our own data that it has got an extremely good specificity of 89.7% and sensitivity of around 98.4%. So it's a very, very useful test. I always feel like a missionary propagating this test, but nothing is happening. Nobody is doing it. In America, in the United States, pediatricians use it in office practice. Of course, nowadays in COVID-19, we don't open our mouths. Also, we don't open the child's mouths. We are very silent now. We wear the mask. We don't put the tongue depressor. Of course, if there is EBV, it's again a clinical diagnosis. Periorbital puffiness, exudative tonsillitis, splenomegaly. It is EBV unless proven otherwise. You don't consider giving antibiotics. Most of the time, pediatricians end up giving amoxicillin or amoxiclav, which will give you a diagnosis by producing a rash after 2 days. There's no need to do that. All you have to do is to do blood count. If you have a doubt, you can do EBV, VCA, IgM antibody, which is highly specific and sensitive. The monospot test is outdated. The other tests are not needed. Only do EBV, VCA, IgM. In immunocompromised individual, we have facilities, you do PCR for EBV. So the bottom line for acute pharyngitis is, please make use of RADT. Throat swab culture is rarely required. Even if the throat swab grows beta hemolytic streptococcus, it may not tell you whether it's a carrier or a true pathogen. In fact, EBV pharyngitis, you do throat swab, you may end up growing beta strep. You need not give antibiotic if there is lymphocytosis. ASO, useless test. Even in rheumatic fever, you must know the community statistics of ASO titers. 1 in 320 only is significant. It doesn't go up immediately. It goes up after 3 to 4 weeks. And lab interpretation is always difficult. And EBV is often misdiagnosed as bacterial pharyngotonsillitis, unfortunately. Case 4. This is a routine case scenario. 11 months old, diarrhea for 4 days, some dehydration, stools are greenish and mucus. Some of pediatricians are very scared of green stools. So much so the mothers and the grandmothers also are worried. It doesn't mean anything. Fever plus and minus. The question that comes to your mind, do you do any microbiological tests for this child? Most often we don't do. Look at this child. The pediatrician asked for a stool culture. And it grew E. coli sensitive only to meropenem and amikacin, pan resistant to rest of the antibiotics. He has also done a rotavirus rapid antigen test, CARD test, positive. The question with these reports, if the patient comes to you, what do you do? The next question is, we always are very fond of asking for like urine routine, stool routine. In fact, I have seen practitioners, when there is dysentery, they will ask for stool for occult blood. When your eyes are seeing blood, why do you want to see blood in the microscope? No need. So when do you recommend stool routine? When do you do stool cultures? And nowadays, new tests are there. Stool multiplex PCR is available. And what is the current status? Let us look at one by one. Now, the film array gastrointestinal panel is available. It costs only around 8,000 to 10,000. And it is a highly sensitive test. There is no question at all. PCR is always very sensitive. And look at this picture. You have 21 targets, and you'll get a report in 1 hour. Bacteria starting from Salmonella, Shigella, different types of E. coli, Clostridium difficile, Campylobacter, everything under the sun is there. You get Cryptosporidium, Amoeba, Giardia. You also get Rota, norovirus, which is emerging in a big way, Astroadeno, and Sapovirus. So when do you do this test? The question is, this is highly sensitive, and in garden variety acute gastroenteritis is a waste of money. You do this if there is an immunocompromised patient. You do this when there is persistent diarrhea. You do this if you suspect something like Clostridium difficile colitis. Otherwise, it's a waste of money. Okay, coming to the stool culture, when do you do it? I always believe stool culture is very cheap. In fact, in our hospital, we charge only 200 rupees for a stool culture. So we have a tendency to use it more often than microarray tests. 200 rupees just for epidemiological purpose. What are the indications? Definitely for dysentery we do to pick up Shigella or Salmonella. And if there is plenty of stool leukocytes, if you happen to do a routine examination, or if you find a lot of blood in the stool, we ask for it. And when there are symptoms consistent with invasive disease, when we are not sure whether it is inflammatory bowel disease or bacterial colitis, we do that. And of course, when there is severe or persistent diarrhea, particularly in immunocompromised children, we do it. When do you suspect Clostridium difficile enterocolitis? How do you make a diagnosis? Is it common or commonly missed? In fact, many microbiologists are of the view that the incidence of Clostridium difficile enterocolitis is pretty high. It's often not diagnosed by us. That's what some microbiologists say, but there is no hard data from India. The diagnosis can be done by 3 methods. One is the glutamate dehydrogenase enzyme immunoassay, which is available now. The toxin assay, which is available. And of course, nucleic acid amplification test in the BioFire microarray. So any of this can be used. The PCR is the gold standard. Cultures are rarely performed. The importance of Clostridium difficile is that you have to stop all antibiotic, give vancomycin orally, and probably metronidazole. So the bottom line from this case scenario is that stool routine is a useless routine. We rarely get anything out of stool routine. Acute watery diarrhea, it doesn't tell you anything. You know, I tell my parents who come with 3-5 days of diarrhea, I tell them, you please pack it like Swiggy and bring it to me. I want to see the naked eye. I want to do naked eye examination. That will give me more information than the stool routine. I ask them to pack it and bring and show me. Stool cultures, beware of fallacies. For example, E. coli, 10 to the power of 5 in the stool, without typing, without knowing what type of E. coli it is. Culture growing and sensitive only to meropenem, don't treat it. Clostridium difficile is underdiagnosed because we do not test. And we must know the limitations of stool culture, rapid tests, and PCR, and use them intelligently. Case number 5. This is a child who had fever for 3 days. The rash appeared on day 3. Blood counts are normal, except maybe minimal lymphocytosis. Platelets are low normal. Dengue season. The question will come to you, what microbiological tests, particularly keeping in mind the possibility of dengue, and how do you interpret them? Nowadays, of course, if this child comes to me, I will always do a COVID PCR before a dengue test. If you look at the dengue test, what is available for us are the 2 tests. One is NS1, the other is IgM and IgG. In fact, recently in our own lab, we have implemented PCR for dengue. In fact, recently we have published an article saying that PCR is more sensitive than any of the other tests like NS1. Of course, it is very costly, but I'm sure it will become the future. Let us look at this graph. You must remember the natural course of all these parameters of NS1, IgG, and IgM in dengue. NS1 is highly specific. There is hardly any false positives for NS1 antigen. And it may become positive within about 24 hours, And in the 1 to 7 days, it can be positive, maximum within 1 to 5 days. And after 5 days, NS1 may not be picked up, right? How about IgM? IgM starts coming up after about 5 days. Look here, this is NS1, which is coming down by day 5, comes down to 0 by 7. IgM starts rising up by about 5 days and then comes down by about 80 to 90 days. IgG starts appearing only in the 2nd week. So if you have a child who has had illness for about 5 days or 6 days, the best option would be to do what is called a duo test. Both IgM ELISA and NS1 ELISA are together available in PanBio kits, right? Which can be used intelligently. Or if the child comes very early in the course of the disease, you can do only NS1. Or if they come very late, you can do NS1 plus NS1. Of course, after 1 week, you don't do. You do IgM and IgG and interpret the test. IgM can have a lot of false positives. NS1 has got very few false positives. What we must do in this COVID pandemic, we should not miss infections like dengue. In fact, quite a few cases in the last 1 month, during the 2nd wave, we have had even dengue along with COVID-19. That can happen. Remember, most fevers with rash require only clinical diagnosis. The child is stable, even NS1 positivity doesn't mean anything. All you have to do is to counsel regarding warning signs. And tests for viral exanthems, of course, are useful only for epidemiology, measles, chickenpox, for public authorities. And I'm sure in future, all these viral exanthems, we'll have a state-of-the-art PCR, which will give you a report in 2 to 4 hours. Multiplex PCR will come for fever panel. Let us move to the respiratory system, where infections are much more common than other systems in pediatric practice. This is a 2-month-old infant who has cough, tachypnea, wheeze, and low-grade fever. X-ray is taken. You see here, the minor fissure is pulled up. You know this is atelectasis. And you are in doubt whether this is pneumonia or bronchiolitis. And you have done blood counts, they are equivocal. how do you diagnose viral infection, viral LRA or viral pneumonia and viral bronchiolitis? And what do? What tests do you do? CBC, CRP, useless, because CRP can go up even in adenovirus infection. CRP can go up in other viral infections. It is not very specific for bacteria. As you have seen, even in COVID-19, CRP can be very high. RSV rapid antigen test do? The patient can afford, do you straight away ask for a BioFire respiratory panel with the nasopharyngeal aspirate? Do you do only throat swab or nasopharyngeal aspirate for a H1N1 PCR? And you also add COVID-19 to this. Let us try to fish for the answer. And let us try to analyze, is there a role for multiplex PCR in LRTI today, pneumonia today? And when do you do them? What about testing for H1N1 and RSV and test for COVID-19? Of course, I'm not going to discuss COVID-19 here. Now, what is available for us is two types of panels in the BioFire. One is this panel, which is the BioFire RP2, respiratory panel 2, where you get a whole lot of viruses and a whole lot of bacteria. You see here, Bordetella pertussis, parapertussis, chlamydia, mycoplasma are there. And all viruses, including the influenza, old corona, it doesn't include the SARS-CoV-2. And recently, the same BioFire company has introduced a new panel, which includes even the SARS-CoV-2 infection also. In addition, there is an advanced BioFire system where multiple bacterial pathogens, including Staph aureus, pneumococcus, everything is included. The advantage is that you will get a report from the lab in 45 minutes. All you have to do is to take an nasopharyngeal aspirate. So 21 pathogens, they claim very high sensitivity and specificity. Once you get a report, what do? Before that, what we do in our institution, I'll tell you. We use the rapid test kit for RSV. It costs only around 400 rupees, maximum 500 rupees. Very easy to do. You get a report within 5 minutes. It's a slide test. We ourselves can do, but of course it is done in our lab. Extremely useful. Very few false positives and negatives. Only late in the course of the disease in RSV bronchiolitis, say 1 week or 2 weeks later, it may be false negative. So acute bronchiolitis, a nasopharyngeal aspirate, if there is a clinically compatible diagnosis, you can use this rapid test and you need not use BioFire. But on the other hand, for influenza, necessarily you have to use H1N1 PCR. And there is a beautiful article in the Archives of Disease Education and Practice, how to use respiratory viral studies. I will share with you what that article says. It says the specificity and sensitivity is much better than cultures. It says it detects multiple organisms. But it always says that it also says that there are several limitations. What are the limitations? In fact, in our own experience, many a time we get a positivity for corona, entro, adeno, everything. So it causes confusion, which is the bug. So some of these viruses, RSV, rhino, adeno, boca, they may persist for about few weeks after infection. Though RSV may go off early, rhino, adeno may last even without causing any symptoms for 4 weeks. And studies have shown if you do it in asymptomatic children, 25% will oblige you with some positivity. And more importantly, 30% of RSV bronchiolitis, you will get more than one organism. And there is no algorithm validated even in United States except for influenza. Bottom line, most of our viral LRIs, if they are mild, don't waste your money in BioFire. But there are some situations in which your BioFire will be very, very useful. The most important being antibiotic stewardship. You have a child who has high counts, X-ray doesn't show consolidation. You have started antibiotics, nothing is growing. In that case, an yield of a virus could make you bolder to stop antibiotics. So you can use it for antibiotic stewardship if it clinically and radiologically fits into a viral pneumonia. Other than that, if there is a nosocomial infection outbreak, RSV outbreak in a nursery, to investigate, you can use it. For stopping and starting antiviral medication. You think it is H1N1 and you start oseltamivir. The PCR is negative, you can stop it. And you are worried about some new virus like Ebola or some metapneumovirus or Boca, then you can do it. Immunocompromised patients, you won't take a chance, you will do that. And severely unwell patients in ICU, ARDS, hypoxia, you will do. And prolonged bronchiolitis, you will do. And more importantly, as a public health measure, when there are multiple cases with RSV, you can always do a quick nasopharyngeal aspirate PCR and cohort them in the same ward, reducing the risk of transmission to others. In mild disease, it is useless. Where it is clearly viral, RSV bronchiolitis in a young infant, it is useless. You don't have to do. And it may not tell you that this is the real cause of the illness. And studies have shown many children can excrete the virus for a long time, particularly immunocompromised children. Even after recovery, the viruses may be identified. So remember all these caveats and intelligently interpret the PCR. PCR is not the solution for difficult diagnosis of RSV, bronchiolitis, or viral pneumonia. Case number 7. 3-year-old child, fever, cough, fast breathing for 1 day. Tachypnea and retractions are there. Total count is 4,600, not high. DC lymphocytosis, hemoglobin low, 9 grams, platelet low normal, 1.7. Admitted as severe community-acquired pneumonia with lot of retractions, X-ray taken. And in the X-ray, you see some shadow in the left lower lobe. Not a typical consolidation nor a viral pneumonia. And your resident asks you, sir, is this atypical pneumonia? Because everything is atypical. Counts are atypical. X-ray findings are atypical. Severity is atypical. Is this atypical pneumonia? At this point of time, your resident might ask you, sir, is this mycoplasma pneumonia? And he would ask you what test is required. Is it a cold agglutinin test, which is cheap? You can do it, 500 rupees. Or is it mycoplasma IgM, is slightly costlier? Or mycoplasma PCR in the nasopharyngeal aspirate or a biofire? Or none of the above? Let us try to fish for the answers. Before that, what are the laboratory clues to the diagnosis of mycoplasma pneumonia, and which tests are useful for the diagnosis of atypical pneumonia? Look at cold agglutinin. I think in 2021, nobody should be using this test. It's 50-50, head or tail. It may be positive in 50% of cases. If it is positive, yes, it may give a clue. If it is negative, it doesn't rule out mycoplasma pneumonia. And even standard textbooks have said this test should be condemned even if the titer is 1 in 64. We don't do it at all. In CMC, of course, they are doing it. I asked them why. They said it is for poor patients. Incidentally, this is a report which is published in PLOS Medicine, where what they did a PCR for normal asymptomatic school children and compared with those who had pneumonia hospitalized in the intensive care unit. And they did a PCR. And shocking to know that the positivity amongst the asymptomatic children was more than the positivity in symptomatic children with community-acquired pneumonia, thought to be due to mycoplasma. So remember, PCR is not the gold standard either for mycoplasma. IgM can be false positive. It may remain for up to 3 months. So what do? Serology is useless, but many recent reviews in pediatric infectious diseases have suggested that if there is a PCR positivity with clinical diagnosis, you treat. Or if there is a PCR positivity with 4-fold rise in mycoplasma antibodies, it confirms mycoplasma pneumonia. The bottom line is the term atypical pneumonia will be out of books, out of literature soon, because we are able to identify the organism. Mycoplasma pneumonia, I always believe giving azithromycin, doxycycline, in severe cases, levofloxacin is cheaper than doing PCR and IgM. The treatment will work. Urinary antigen for Legionella and IgM for mycoplasma IgM for chlamydia, cold agglutinin are useless tests. PCR in BAL or nasopharyngeal aspirate, we have to use it with caution for antimicrobial stewardship. My last case, 4-year-old child, fever, 103, cough and retractions, again tachypnea. Total count is 22,000. You get a beautiful consolidation like this. Okay, you know the commonest cause is pneumococcus. But then, how do you prove? What is the bug? That's the next question. So how do you prove this? How do you prove the bacterial etiology? What are the recent advances in the diagnosis of pneumococcal pneumonia? If you look at literature, the yield from blood culture in pneumonia is very low. In fact, in our own hospital, our statistics reveal 10 years back, our yield was at 3%. Now it's around 7%. And internationally, they say only 10% yield you will get in blood cultures. And of course, somebody might do mycoplasma, IgM, IgG with all its limitations. And somebody might do PCR from respiratory secretions, sputum, nasopharyngeal aspirate, nasal swab, throat swab. And now blood PCR is being tried out for pneumococcus. And if you have empyema or pleural effusion, you can do pleural fluid, RT, PCR, or Binax, which is a rapid antigen test which is used in the pleural fluid. And urinary antigen for pneumococcus can be used above 5 years. I'll come to it later. And nowadays, people are very fond of rapid detection tests. You look at this figure, which gives you 6 panels by the BioFire company, which all do multiplex PCR. All these, you will get a report within 45 minutes. First, the respiratory, which I showed you earlier. Now they have come out with an advanced respiratory pneumonia, which includes Staph aureus, pneumococcus, gram-negatives, etc. And a CSF BioFire, meningitis encephalitis panel is there, which include pneumococcus, H. flu, cryptococcus, and several viruses, including HSV, HHV6, adenovirus, enterovirus, etc. They have gastrointestinal panel, which I already showed you earlier. And they have a blood culture identification, which gives you a report within 2 hours. And they have one panel for bone and joint infections, which, in addition to picking up Staph aureus, about which we all know a lot, it also picks up Shingella. Shingella is one organism which causes septic arthritis and osteomyelitis very commonly below 4 years of age. The importance of knowing it is that if you use cloxacillin alone, it won't act against Shingella. Clindamycin won't work. You have to use a 3rd generation cephalosporin. Unless you do PCR, this Shingella cannot be picked up. So here, this is where the BioFire becomes useful in bone and joint infection. These are the panels that are available. But mind you, if you ask me, do you use all of them? The answer is no. Be definitely useful in CSF. If you don't get the clues with the gram stain, sugar, protein, and cell count, we do use it. It's most useful, cost effective, because it picks up pneumococcus, it picks up your HSV, it also picks up HHV6, in which case you don't have to give any treatment. But then there is a limitation. It doesn't pick up Japanese encephalitis, which is common in your setup and our setup. We use it judiciously in RTI, child hypoxic, non-responding pneumonia. We use in intensive care settings. GE panel, we very rarely use it. We use it only when you think of Clostridium difficile or unusual cause of colitis or in immunocompromised children. What is new in these tests? What is happening? What are the advances? The most important advance is what is called MALDI-TOF. What is this MALDI-TOF? With matrix-assisted laser resorption and ionization of light mass spectrometry. It's very difficult to remember. Like, we are not biotechnologists. So MALDI-TOF, what does it do? It identifies the pathogens within hours and is very fast. It is based on protein technology. It's proteomics. Let us not try to complicate it by trying to understand more. What they do, they identify the essential protein present in the bug, whether it is a bacteria, mycobacteria, fungus, parasite. It gives you a report very fast. It also gives you a report about the sensitivity. For example, for diphtheria, in our own hospital, we don't have culture facilities. We send it to CMC Vellore, where they do a multi-DOF, and they give a report within half an hour. They have a system. It goes into the system. That report comes out almost like Gene Expert. It gives you a report in few minutes. But the disadvantage is that you must have enough number of organisms which will be grown in culture. Highly sensitive. And it will identify the bacterial specific species. It will identify the toxin of diphtheria. And it will also tell you whether this is resistant or not. TB, MRSA, ESBL, everything will come. The machine costs around 1 to 1.5 crores. It's there in CMC, it is there in many hospitals in Mumbai, Delhi, etc. Even in Chennai, some centers have it. But the platform has not been fully validated. And I'm sure it will become cheap, like many of our vaccines, very soon. And we'll be getting reports in few hours. The other technique is, of course, 16S RNA, which is based on a sequence-based technology, where you identify the ribosomal sequence database in various organisms. And this, we do use it in difficult cases like brain abscess, PUOs, etc. It's very costly. The problem with that is, again, very high sensitivity. You may end up, in fact, many a time in the 16S RNA reports, we find reports of some organisms which you cannot spell at all. We have to again go and beg the microbiologist, please give us the significant. But it's an emerging technology which will be refined. Having said that, so many modern tests are available. PCR is there, rapid BioFire is there, 16S RNA is there. You have rapid antigen tests. You have multi-DOF. You have so many new tests, Gene Expert Ultra, okay, TrueNat. All the modern tests are there for us. What does a poor general pediatrician do with regard to these tests? I'll tell you what we should do. As clinicians, the first and primary responsibility for us is a good clinical evaluation, good history and physical examination. And we must all practice diagnostic stewardship. What is that? You must ask for the right test for the right patient at the right time. And then you order the rapid diagnostic test. Take help from the microbiologist. He will tell you. You have to tell the microbiologist the syndrome you are diagnosing. Then ask her or ask him, what do I do to quickly get the diagnosis? And then you perform an appropriate rapid diagnostic test. And then the microbiologist will give you the report as early as possible. And you discuss with him or her, and then practice. After practicing diagnostic stewardship, it's not over. You must practice therapeutic stewardship, antimicrobial stewardship. You must have the right interpretation. You must choose the right antimicrobial at the right time, at the right dosage, at the right route, and the right duration. And then you give a treatment. The patient is going to become all right and going to thank you. With this, I'll end my discussion. Thank you very much for listening to me. Thank you, Dr. Ananda Kesavan, for giving me this opportunity. As I promised, I have finished exactly in 50 minutes. If there is any feedback, positive or negative, please mail to sbsped@gmail.com. Time for questions from the audience. Thank you.
Yeah, thank you, sir. We had lots of questions waiting in the chat box. So thank you for the wonderful session with the beautiful cases, latest microbiological test. And I think all my senior colleagues will agree. The old microbiology is gone. Now it is area of FIM and multiplex PCR and so many new tests which are not known. Before starting question, I'll ask 2-3 questions from my side, sir. One is that you mentioned about a rapid test everywhere, but not mentioned the urine. What about the urine nitrate and glucose test? We are not using in this part very commonly. What about to use this one? Second, you mentioned the case of Mycoplasma pneumonia. A 3-year-old child. Is it, it is not completely 3-year-old child mycoplasma not very common in this part. The third thing, is there any doubt about overusing lab test already? Clinical scenario, clinical science and demonstrate everything going on. Now it is an old art. Some people at least consider like that. Then already so many tests are there. Now newer and newer tests coming. That means that our clinical skill still will we lose our clinical skill further. So I want to get your opinion from this one also. 3 questions from my side.
First, I'll take the first question. As I said, I wanted to restrict myself to microbiological tests. That's why I didn't discuss nitrite and leukocyte esterase. If you ask me whether we are doing it in our lab, yes, as part of the dipstick, we do the nitrite and leukocyte esterase. Each one has got around 75 to 80% sensitivity and specificity. First, nitrite in the presence of coliform organisms, yes, it may be positive. Nitrate has got more specificity and sensitivity than leukocyte esterase. Leukocyte esterase can be positive even in the absence of infection when there is inflammation in the kidney, including Kawasaki disease, right? So it is not specific. Both the tests, they don't tell you anything. You can't diagnose UTI with nitrite and leukocyte esterase. They have got limited specificity and sensitivity. They are only screening tests. The best is a good microscopic examination. In fact, as you rightly pointed out, I read a paper saying that the best test is a gram stain of centrifugal urine. That's the most sensitive test. They can give you a report within half an hour if the microbiology is good. 1. 2, as regards to clinical sign, foul smelling urine is a very sensitive test, clinical test, right? So nitrite, again, leukocyte esterase, neither nitrite negativity nor leukocyte esterase positivity or negativity is going to exclude or confirm diagnosis. It is only culture. That is answer to your first question. Answer to your second question, I'm glad that you asked. The thinking that mycoplasma occurs below 5 years of age is an old thinking. There is enough data that 25% of pneumonia, even below 25 years of age, can be due to mycoplasma. So that is an old thinking. Mycoplasma is considered an adolescent disease. No. And earlier, it was thought that chlamydia is more common in under 5 and mycoplasma more common in above under 5. No. In fact, a lot of data on mycoplasma has come, unfortunately, from China. So people are skeptical about it. But it can occur in a 3-year-old. I wantonly put it at 3-year-old, mainly because mycoplasma can occur in any age. Though I agree with you, it is more common above 5 years. Just because the child is 3 years old, please do not rule out mycoplasma. We have seen even autoimmune hemolytic anemia with proven mycoplasma in below 5 years of age. That can occur. That is number 2. Number 3, what is your third question? Yeah.
Clinical skills and the newer test. Just an overview.
Dr. Anandakesan, I'm only quoting literature. I'm not simply mentioning my personal experience. I'm only quoting. Similarly, I'll tell you, there are several myths about mycoplasma. One is that people used to think that if there is pleural effusion, it is not mycoplasma. It is wrong. 25% of mycoplasma can cause pleural effusion. People used to teach if there is lobar consolidation, it is not mycoplasma. It is wrong. It can cause. So mycoplasma is a mimicker. The only controversy in mycoplasma is that mild to moderate mycoplasma pneumonia, there is no evidence that treatment influences the outcome. Whereas in severe mycoplasma infections, antibiotic therapy might help. I'm quoting Cochrane review, might help. So let us not think that mycoplasma does not occur below 5 years. It can occur. I agree with you. It is more common above 5 years. Third point.
Sir, about that, you mentioned about China's data, but what about...
Allow me to complete. Allow me to complete. I listen to you patiently. Third point you said was lack of loss of clinical skills. Yeah, that we all know. But at the same time, let us not decry new tests. I'll tell you, if you go by the WHO algorithm, all tachypnea will be giving antibiotic. Okay, all retractions will treat as severe pneumonia with antibiotics. But in future, I am sure there will be good tests to tell you whether this is viral or bacterial. In fact, recent developments have shown a method. In fact, the same BioFire platform is being refined where they do the PCR and they also assess the density of the virus. And they try to give you a report whether it is likely to be true infection or colonization or long persistent. So technology is emerging. Technology is not always bad, but technology, remember, see, the same thing happened to TB. You say clinical skills. 20 years back, any child with fever and cough, weight loss, it is TB. If everything is negative also, we used to give ATT. Now we don't do that. Gene expert is helping us. Technology is a double-edged sword. I agree with you. Clinical judgment is important. New tests may initially be very exciting, like a new wife. Always, you should not end up in divorce. You should result in only honeymoon and also result in a few pregnancies.
Okay, sir. Now, even though your talk is about microbiological aspects, some other questions are there. First question, what is the role of Shigella PCR in suspected Shigella encephalopathy? No blood in the stool. Because we had an outbreak of Shigella in Calicut and Ernakulam, Kochi. That is the question from Call Code. What is the role of Shigella PCR in suspected Shigella encephalopathy? No blood in the stool.
Extremely good question. Shigella can cause watery diarrhea or bloody diarrhea. And Shigella can cause encephalopathy even if it doesn't cause bloody diarrhea. Shigella can cause a minor diarrhea and septicemia similar to typhoid and cause encephalopathy. If you have a child with diarrhea, and if you have a child with diarrhea and encephalopathy, worthwhile doing a stool PCR. And Shigella is not a commensal in the stool. If PCR is positive, the child is having encephalopathy, yes, it will give you good evidence that it is likely to be Shigella encephalopathy. As I rightly said, any test report has to be interpreted with the clinical data. In a given scenario, like what you're saying, if there is encephalopathy, if there is diarrhea, just because blood is not there, I will not say it is not due to Shigella. Well, you have several strains of Shigella. Even Shigella can produce toxin and can produce watery diarrhea, also very similar to cholera or enterotoxigenic E. coli. So that can also cause encephalopathy. So PCR, yes. Stool culture, if done properly, also is useful.
So next question, in a clinically diagnosed case of bronchiolitis, should we do investigation to know the etiology?
The answer is not needed. So very simple, very simple. I don't do for all cases. See, I do only when there is a doubt. Only when there is a doubt. In fact, as part of our hospital project, we have done RSV-400, the nasopharyngeal aspirates, and we have proven that below 5 years, even in a two-year-old children, RSV is the most common pathogen. If you look at the recent data on the pneumonia studies, RSV has emerged as the most common pathogen causing pneumonia and not pneumococcus. So if you think child is having mild bronchiolitis, you need not even admit, you need not do any test, you should only counsel. Only when there is severe bronchiolitis, when you have a diagnostic dilemma, what it is, yes, it could be of help. In fact, I will also tell you, we have been surprised with the respiratory BioFire, where we have picked up pertussis in young infants, where clinically there is no woof at all. PCR coming as positive. Bronchiolitis or viral pneumonia-like picture. So I don't think, because that becomes epidemiologically useful if you diagnose pertussis. So I won't decry all these tests, but I won't be wasting my money for every patient. Agreed. There is no need to do for mild bronchiolitis.
So one question is from Dr. Srijit. What is presence of toxic granule and again CRP? Can be taken as a bacterial sepsis. How much we can rely on toxic granule and CRP for bacterial infection? We are not covered this aspect, and then also you can answer, sir.
Okay, toxic granules is a very, very unreliable pathological finding. In fact, my pathologist tells me that toxic granules, the appearance might come if the distilled water that is used in preparation of the slides is contaminated. So it's not reliable. That is number one. Two, the presence of toxic granules tells you that there is immature neutrophils coming out, right? But I still remember, I'll tell you, if there is a traffic jam in the Thrissur bus stand today, you see a big traffic jam, immediately you can't say there is a communal riot in Thrissur. It may be because the chief minister is coming, or the governor is coming, or some marriage procession is going on, or there is a communal riot. So like that, toxic granules tell you that there is something going wrong, but it doesn't tell you it is bacterial infection. Never should anybody start antibiotics just because somebody reports in the peripheral sphere toxic granules. So it is useless. Coming to CRP, CRP is an acute phase reactant. It has replaced ESR. In fact, I have always heard quite a few senior adult ID physicians saying pediatricians are obsessed with CRP. Okay, I am, including me, now with this COVID-19, right? But again, you should interpret it with caution. CRP has got more negative predictive value than positive predictive value. A negative CRP is more useful than a positive CRP. CRP goes up in 6 hours, comes down very fast. It is a good inflammatory marker. That doesn't mean CRP of 24 means bacterial. CRP less than 6 is always viral. No. There are 2 or 3 situations in which CRP can be effectively used. One, if you are thinking of a bone and joint infection, for example, you have a child who has got arthritis or severe arthralgia. If you do a CRP, if the CRP is negative and done in a proper lab, it nearly rules out osteomyelitis. I say I'm very cautious in saying it nearly rules out. It doesn't have 100% sensitivity. It nearly rules out acute osteomyelitis and septic arthritis. That is one. Two, a CRP more than 75 is significant. You won't ignore. It tells you there is inflammation, but it's not always bacterial. There are few infections like CMV, adenovirus infections, where CRP can go up without bacterial infection. Third, today, amidst COVID pandemic, if you see a CRP of more than 150, this is what I can quote from our experience. Please think of Miss C. The only other condition in which CRP goes up so high is pneumococcal pneumonia or pneumococcal meningitis. So if you get a CRP from the lab, it is 200. Today, epidemiologically, please start. That doesn't mean you straight away diagnose. You start thinking of Miss C. Last but not the least, if you have an adolescent who has got prolonged fever, you find ESR is 100, CRP is negative. It is SLE unless proven otherwise. CRP notoriously doesn't go up in SLE unless there is some pleuritis, pericarditis, or secondary bacterial infection. In garden variety SLE, CRP is negative, ESR is elevated. This discordant must be kept in mind. Again, like all other tests, CRP must be used intelligently.
Now, what is the prevalence of macronode resistance in mycoplasma infection?
There is no data from India. I can quote a Chinese paper. 90% of mycoplasma isolated in China as well as in Vietnam or Philippines, I don't remember, some Southeast Asian country, 90% of strains are macrolide resistant, out of which 2/3 are resistant to doxycycline and tetracycline. So in severe mycoplasma, if you are pushed to the wall, I would use levofloxacin to save the life.
So in a child with the LRT or pneumonia, can we rely on biofire respiratory panel on nasopharyngeal swab, if there's no facility for BAL or sputum, can we use nasopharyngeal swab?
The ideal is sputum. If you are able to get sputum, nothing like that, you do a culture. That's a gold standard. If you are able to perform a BAL, it is better than nasopharyngeal aspirate. But we don't do. The only thing we often do is a nasopharyngeal aspirate. There is always a risk of contamination of the nasal flora when you do a nasopharyngeal aspirate. It's not the best of tests. That is why there are so many problems with regard to interpretation of nasopharyngeal aspirate. You sacrifice specificity when you go for molecular tests by increasing the sensitivity.
There are some more questions, but we got a very serious and a very good teachers are here. I will ask to first to give a comment by Dr. Srinivasan sir, retired head of the department from JIPMA. Srinivasan sir. Unmute sir. Srinivasan sir. I ask Dr. Subramaniam. So, what is your experience regarding mycoplasma pneumonia? You are about a newer setup. Dr. Subramaniam is a president of a national chairman of the IEP respiratory chapter, head of the department from Bangalore. Dr. Subramaniam?
Yeah. Am I audible?
Yeah, audible.
Yeah. Congratulations, sir. Balasubramaniam, sir. It was a treat to watch you. Thank you very much. But first of all, I would make one comment followed by answering to your question, Anand Keshavan, sir, if you could permit me. First of all, I would only think that is a test going to make a diagnosis which I have not made clinically. Then only I will order test. Second thing is the setting in which I am there, whether it is going to be cost effective and the patients and parents can afford it, and is it going to make difference in the management and outcome for the child? That's the most important parameter rather than our academic cherish. But I would say the golden academicians should do the tests, because that's when they throw the light on the real prevalence. Otherwise, we will be in our own boxes thinking that whatever we are doing is correct. So only when the new things come and we keep on exploring, like suppose our SBS sir is continue to do biofire tests and go on recognizing the fauna and flora in the respiratory tract, we will at least know the change in epidemiology in at least southern part of India, and then therefore we can extrapolate the data. So therefore always there should be some kind of encouragement for doing tests in the apex institutions outside the box of indications. But when it comes to community pediatricians, what I would say in general practice, which empirical therapy would be the best, and that answers the question on bronchiolitis and couple of questions on pneumonia. So mild to moderate diseases, there is not going to be change in the outcomes as far as the investigations are concerned. And I think, as Dr. Balasubramaniam said, routine investigations are just routine, and their opinion will also be routine and is often most expected. We see counts going up or down, whether we like it or not, and doesn't make any difference. Please forget the routine investigations, and I think you should ask for specific investigations. But when you ask specific investigation, it only means that you have already made up your mind as to what is the clinical diagnosis, because routine investigations are just written or ordered without thinking or without making a clinical diagnosis. I think this is point number one. Coming to Anand Keshavan sir, your question on prevalence of mycoplasma pneumonia, I would consider in situations where the primary therapy with the penicillin-like group of drugs failing to act, which means that those antimicrobials which act on cell wall, like amoxicillin or maybe cephalosporins, do not work. That is when I will think why it doesn't work. Probably apart from complications or progression of the disease, or apart from the pandemic that we are looking for, the only reason why a penicillin-like drug could fail is because the organism may not have cell wall. Clinically, that only means that probably you try something else that works on another mechanism. It need not be a typical organism. It could be that you hit by other way. If I look at only from management perspective, I would say non-amoxicillin responding pneumonias can be macrolide responding pneumonias. This is the way we would look at rather than, atypical. And atypical is not one atypical. There are hundreds of organisms. Each one is typical by it in its own style in clinical manifestations and outcome. Therefore, all atypicals cannot be grouped together to give an atypical feature. So therefore, you must also ask a couple of epidemiological questions. Were there, I would say, air conditioners, this, that, etc., travel, all those questions are important apart from age. I think that's important. The age factor is coming only because we are giving penicillins or alike drugs based on empirical treatment based on the clinical diagnosis and as a function of age. And therefore, the question, every time the question on age comes for atypical pneumonia. That's because we are too much biased by the age as far as our choice of antibiotics are considered empirically. And that's why the question always asked by the audience regarding the age. So age is not a bar for the organism, and it's not that there is any extra predilection, but only because that we are focused on under 5 mortality. Therefore, we don't want to overuse azithromycin, which has high prevalence of macrolide resistance. We are not using it either as a first line or as a combo therapy. And I think Dr. Balasubramanian, you agree with me on these comments. And if there is something which I have forgotten, you may please add.
I think excellent thoughts, very rightly put by you. But one point to the audience I wanted to stress here is that below 3 years of age, even if the clinical picture suggests it could be atypical pneumonia, it's better not to use a macrolide alone. The reason is, below 3 years, bacteremic pneumonia is much more common than mycoplasma or chlamydia. And for bacteremic pneumonia, macrolides are useless. When there is bacteremia, even if the pneumococcus is sensitive to azithromycin or erythromycin, you may fail and end up in having other forms of invasive pneumococcal disease. So if at all you use a macrolide in a child below 3 years, except in pertussis, you always use in combination with the beta-lactam antibiotic to cover bacteremia, which is not going to be picked up because most of us don't do blood cultures for pneumonia. That's one. The second important point is that if you look at the Cochrane review on macrolides, for mild to moderate pneumonias thought to be due to mycoplasma pneumonia, treatment is not known to alter the outcome. If you read the 20th edition of Nelson, it is clearly stated that in the presence of clinical features of fitting in with mycoplasma pneumonia, if you have PCR positivity, most infectious disease specialists advocate therapy against mycoplasma, though whether the outcome is altered by the therapy or not is not known. In fact, I can tell you from my own personal experience, where we are doing a study on mycoplasma. We are doing paired sera for mycoplasma antibodies, and we are doing a PCR. And we have done about 93 cases. Unfortunately, because of the COVID-19, we are not getting lots of pneumonias. So the number of cases is very low. We expect to complete the study and come out with probably good data. And I can tell you in our own series, the yield for mycoplasma PCR appears to be pretty low when compared to the Western data. Right? That's it. The second thing is chlamydia pneumonia from South India. Again, Dr. A. Balachandran, way back 20 years back, he had published data that the incidence can be as high as 20 to 25% in the community settings in pneumonia. So please do not forget chlamydia also, which again is one thing which will respond to macrolide. And of course, pertussis will respond to macrolide. And in addition, Subramania knows very well, macrolides act by anti-inflammatory action also. Any pneumonia, if you add, even for COVID pneumonia, if you add macrolide, it may have a benefit by its anti-inflammatory action. So we don't know whether that is working or is working against Mycoplasma pneumonia. It's a never-ending argument. So that's what is all about Mycoplasma pneumonia, a blind area for the pediatrician.
Thank you,
Sir,
sir. Now
sir,
invite
sir,
Dr.
Anand Keshavan, sir, I want to just quickly ask Balasubramanian one question. Sir, why in Government of India, WHO and international guidelines, knowing that the COVID, SARS-CoV is a viral, in the lower respiratory management, why they have added antibiotics? And if we start giving amoxicillin or doxycycline to Tom, Dick and Harry in a pandemic situation, what would be the emergence of amoxicillin or doxycycline resistance? Are we doing on one side antibiotic stewardship, and on the other side in a pandemic situation, out of panic, are we over prescribing antibiotics? Sir, your comments on COVID plus COVID management and antibiotics.
I'm unable to answer you directly, but I can tell you, see, the Government of India guidelines are not meant for pulmonologists like Ananda Kesavan or Subramania. They are meant for healthcare workers and peripheral doctors. I think they can't diagnose pneumonia confidently. That's one of the reasons why the Government of India has probably given. See, we all agree. I'll ask you one question, Subramania and Ananda Kesavan. Do you go by the WHO algorithm and say respiratory rate is more than 40 above 1 year, you start giving antibiotic? Definitely you won't give. See, that is for a healthcare worker, for a peripheral doctor. We cannot extrapolate everything to us. Ultimately, it is clinical judgment. In fact, I have been saying in the last few months, and unlike pediatricians, we are very much used to viral infections, viral fever. We are very much used to these breadwinners. So we know how to treat them competently without antibiotics with confidence. But unfortunately, please I mean no malice against adult physicians. They are only used to diabetes, hypertension, and coronary heart disease. They are now deluged with infections. So that is one of the reasons why so much of antibiotics is being used by adult physicians and pulmonologists. Yes or no, Subramania?
We agree, 100%.
That's what is happening. So let us be still judicious. Let us not simply say WHO says this and we will use it. I think WHO module is only I will always say, it's a beginning. It's just a beginning. Child has got wheeze, you're not going to give antibiotic. Child gives past history of wheeze, there is mild tachypnea, you're not going to start antibiotic. So clinical judgment.
We have comments from the Dr. V.K. Pardi, past state president of IAP and the retired head of the department. V.K. Pardi, senior madam. I think Balasubramanian sir, no, sir, very well.
Madam,
thank you, Balasubramanian sir, for the wonderful talk. Thank you. Regarding the suprapubic aspiration for urine culture, previously people used, especially the pediatric surgeons used to say that it is the best. And what is your...
Yeah, I agree. In fact, I still remember 20 years back in one of the panel discussion, when I talked about catheterization, everybody jumped on me saying it is invasion. Now the whole world has agreed if you take all precautions, that's the best way. And suprapubic aspiration, which I used to do as a postgraduate, many a time I used to get blood rather than urine. We have stopped doing it. Even in newborn in our hospital, we have stopped doing it. We are only catheterizing. Catheterization becomes a problem only when there is severe phimosis or there is vaginal synechia. In which case, we call the surgeon, they retract the prepuce and do it, or they open the synechia and do it. That's what we do. We have hardly done any suprapubic aspiration in the recent past. Even literature says, even the AAP guidelines on urinary tract infection says catheterization is as good as suprapubic puncture. You see, the technique is very difficult. Interestingly, there is a Chinese method called tweak method, where I believe you can stimulate the up-down valve. You can wait like Dhoni and catch the urine and give it. So I think best is urine culture with a catheter. It's not invasive. If you take proper aseptic precautions, it's not dangerous.
And I request Dr. Purushothaman, sir, head of the Department of Pediatrics at GMC Thrissur, to give some.
Thank you, sir. That was an excellent talk. And last comment with Dr. Subramanias, maybe in the coming year, 2022, we are going to have more and more cases of resistant organisms of all sorts, especially azithromycin, doxycycline is going to be useless for the leptospira, rickettsials, which we are encountering, and very good response to rickettsia with both the doxycycline. Both the azithromycin and doxycycline are going to be almost useless for those purposes. And all the high-end antibiotics also, even though it's being used in the adult population, we'll find it more and more of a resistance in the next year. And one more thing, sir, we should have considered the possibility of a range of fungal infections also, which is likely to come in the year ahead, because of the burden of the organism in the environment. It's the fungus is high, all sorts of fungus are there, and maybe that also may contribute to the pattern of infections in the pediatric age group in the coming months itself, not in the year. That is one point. Thank you.
Agreed. Hopefully, we won't have much severe COVID and much severe MISC, and hopefully we won't use as much steroids or as much immunosuppressives as it is often required in adult COVID. Hopefully, we won't get many children coming with mucormycosis, etc.
Now, last comment from Dr. T.D. Mulidhran, head of the Department of Pediatrics from Government Medical College, Palakkad. Muli sir, any comments? Unmute. Unmute. Unmute, sir. I think that's not a. Yeah. Yes, sir.
It was a wonderful talk, Dr. Balasubramaniam, and it was very interesting, and to keep us in pace with the advanced methods of diagnosis in the biophysical profile. Thank you, sir, very much.
So now you request the chairperson, Dr. Anju, to conclude the session before the vote of thanks. Anju, just to sum up the salient points.
It was an excellent talk. I think sir covered almost everything. And as it was case-based presentations, I think it was very clear to everybody what to do and more importantly, what not to do. So I think the point is well conveyed to the audience. Thank you, sir, for enlightening us with such an excellent talk. And I thank IAP Thrissur also for the wonderful program that they have arranged, and they are doing a very good job in bringing this series. And Anandageshan sir is actually steering the program very well. Thank you, sir.
So thank you, Balasubramanian sir, and all the senior teachers, friends, colleagues, and students. It was really a wonderful session. And Dr. Subramaniam and Dr. Yogesh Pedike, so many 50% of crowd from outside Kerala. Very happy to see this wonderful crowd. Today we have 3 concurrent sessions going on: Kasaragod, Kannur, Pathanamthitta. And before vote of thanks by Dr. Srijit, Balasubramanian sir, you have to say something?
Just one comment. I would say that for me, giving a talk to the audience from Kerala is like a cricketer playing at Lord's Cricket Ground. I'm so privileged and proud. Thank you very much.
And I invited Dr. Srijit Kumar to propose the word. He is the secretary of IAP Thrissur.
Thank you, sir, for inviting me. Actually, this is the 4th talk on our Thrissur talk series, and today we have a full house of attendance, and those who have attended had rewarded very much from the excellent talk from Balasubramanian sir. It's an ideal mix of new evidence, the practical points, and what the future holds. So excellent talk and a lot of learning points from this talk. Thank you very much, sir, for joining us for IAP Thrissur, for accepting our invitation and giving a talk. And also thank all the senior faculty from Srinivasan sir, Yogesh Padik sir, Purushothaman sir, and Muralidharan sir, Sarojam madam, Parvati madam, and also the office bearers of the IAP Kerala and IAP Thrissur, like Jayaraman sir, Johnny sir, and Anju Deepak madam, and Mukesh sir for inaugurating the session. And I also thank all the audience who have joined for this meeting. And before going back, I remind you that another program is coming on the Sunday morning at 8:45. Pediatric endocrinology CME is a half-day CME based on pediatric endocrinology emergencies doing with the IAP Kerala. So hope you all of you to join on that meeting also on 8:45 on Sunday morning. So thank you for joining us today, and thank you, sir.
Thank you, sir. Subramanian sir.